With us is Dr. Joe Congeni, Sports Medicine Center, Akron Children's Hospital. We always like to talk sports medicine with us. And, Joe, I guess let's start right there. Andrew Miller last night, 46 pitches. He's been pitching a couple of innings for us. That's kind of a lot of pitches for him. How quickly a guy who hasn't been stretched out that way can he come back, pitch the next day? I mean, can he go and throw 15, 20 pitches tonight, or is it best to rest that big left arm?
I mean, you know the deal is certainly different things than we're going to tell our youth pitchers and our high school pitchers and the World Series. The World Series, you know, all bets are off, and I heard your interview this morning with Corey Kluber, and he said, I'm going to be used anywhere I'm needed to get us 4 wins. We just want to get to 4 wins first. And Tito just measures it by outs. How many outs does he have to get? I don't think he can count on any outs from Andrew Miller tonight. Typically for a reliever.
Because he hasn't been stretched out, is what you're saying, right?
Yeah, because he hasn't been stretched out, and I just think that, you know, the fact that he's going multiple innings, and Tito has this thing I've heard him talk about, which are called stressful innings. So you'd say the ninth for Cody Allen was pretty much a cruising ninth, just to get out there and get his win. Would you say that the 2 innings that Miller was stressed to the wall, every one of those pitches was stressful? So no, I don't think Andrew Miller will be very helpful tonight, but you've got some other arms out there.
Well, and one of them is Danny Salazar, and I know they've worked him out in simulated games. From a medical standpoint, just so the average fan listening to us this morning understands, they saw Salazar as a starting pitcher through the first 3 or 4 months of the year, and they said, well, we got Salazar. Let's put him back in the rotation. It's easier said than done.
Yeah, I mean, it took a long time, didn't it? I mean, we were looking at the beginning of the, you know, early in September when he went down. So we said this is going to take a while. It did. We're lucky enough to be playing the last week of October. They would not have put him on the roster, believe it, if he couldn't help this team in some capacity. I am told he could go 3 or 4 innings, and in an emergency start situation in a game 3 or 4 or 5, that may be where we use Danny Salazar, maybe in relief too. Who knows?
Well, you could always throw him in there like they did in that one game with the bullpen. You go 3 innings, and then you turn it over to Otero, you turn it over to Miller, and you go on out and try to patch a win together. But game 2 tonight is at 7:08. Okay, let's talk a little bit about Botonio, the offensive lineman for the Browns. He's got this fracture in the foot again.
Yeah, I mean, the only reason that's worthwhile, people really scratch their head at the name of this thing, and it's the dreaded injury in sports, and it occurs in high school kids. I'm managing a couple high school kids right now, together with one of the surgeons down at our place, with an injury called a Liz Frank fracture. And it is a misnomer all the way. First of all, a long French name. And the reason for the French name is in the French army, Napoleon's army, the horsemen used to ride when they fell off their horse. They broke the middle of their foot. And basically what they would do at that point, Ray, amputate the lower leg.
Wow.
And so these horsemen would have this injury, and it was named after the most famous French horseman. His name was Liz Frank, and it stuck, the Liz Frank fracture. And so... But it's a spectrum like so many other injuries. So it's a midfoot sprain, not an ankle sprain. The foot is sprained, and the ligaments in the middle of the foot are the part where it tears. It spreads the bones apart. It has to be fixed. People can't run and push off without having it fixed if it's a grade 3 complete tear. Grade 1s and 2s can return to play. Sometimes they swell so much we put them in a cast for a couple days, maybe get an MRI in a high school kid and see later. But if they can't continue to go on, they would need to have surgery done. And that's the same in high school, and that's the same with Joe Botonio.
Sometimes with these foot fractures, they're different. I've had a number of friends who said, well, I got a sprain in my foot, or it's a little bit sore. And then a couple weeks later, they say, oh, they found a fracture in there.
Yeah.
Is that kind of common?
It is, because many of these
there's
you can't
so many
see.
bones.
Yeah, these you can't see initially when there's tremendous swelling in some of these. You can with a Jones fracture, and people do very well with a Jones fracture, like the number 1 NBA pick. On a Liz Frank, not always, and you have to go to an MRI quite frequently to differentiate these, and you don't do that right out of the chute. Sometimes, like I said, you let the swelling go down in a boot or a cast in a high school kid, and then if it's not going down and you're worried about that area and you can't see it, you may need to get an MRI because it's a management issue. Part of the debate about why are we seeing these Liz Frank and foot injuries so much more of course, what we always say, bigger, stronger, faster athletes. Number 2, everybody playing on turf. Number 3, nobody wears the big clunky shoes that we used to want to wear. Athletes want the lightest shoe possible. They want to get it down to the lightest shoe, and speed is everything. And they have almost no support in a lot of the shoes they wear, even at the pro and college setting, let alone the high school setting. And the shoes have very little support, and that twisting injury of the foot can lead to this injury called Liz Frank.
So you're saying like the twisting, I was trying to understand why you mentioned the field turf type of thing. Is that because on natural surface, natural grass, you get a little bit more give with the ground?
Exactly what I was going to say. There's a little bit more give. And so the deal is, right from high school all the way through the college and pro athletes, we see a lot more of these sprains to the foot.
Dr. Joe Congeni with us, Sports Medicine Center, Akron Children's Hospital. For parents, grandparents, or just athletes out there listening to us, if they've got a sore foot from some athletic event, what is a giveaway that maybe it's more than just a sprain and you got a little swelling down there? When is there something that says, hey, you might have a fracture in there?
That's it, Ray. I mean, swelling, the first couple of days, bruising, inability to bear weight. So we could live with that for a couple of days of ice and elevation. How many times on a weekend on calls I get do I say wrap it for compression, ice it, elevate it? They should be walking and improving by Monday, Tuesday, Wednesday. They're not bearing weight well. They're swollen. They get into bruising over a period of time, significant swelling. There's something more going on, and we need to evaluate it further, starting with a plain film x-ray.
Okay. You also wanted to touch on some new stuff in regards to fighting these concussions again.
Well, just one thing that is the mobile sideline exam room, training room. I don't know if people have seen these. These are in the college setting. When they're in the college setting, we'll be seeing them probably next year in the high school setting. These pop-up units where we can do examinations on the sidelines. It's like a tent type material. It pulls over the athlete. The training table is in there. So the exams take away from that spectacle-like event, even in the high school setting when the medical team is examining somebody's head or they're examining somebody's foot or knee and everybody's watching what's going on with the exam and there's no privacy to that exam, yet not taking away the medical team. The whole medical team has to go in the locker room or the training room. Alabama came up with the sideline pop-up training room. And so what happens is they pull this over the top. It takes 10 seconds to pop it up and pop it back down. It doesn't block the view for those Crimson Tide fans, so they're missing part of the game, but it gives privacy to the medical team and the injured athlete, takes away the spectacle part of it. And I'm very confident in the entrepreneurship in our country that you'll be seeing it. Now, there's 5 or 6 colleges that have it. Ohio State has a version of it. Next year, we'll probably be seeing it in the high school setting.
Dr. Joe Congeni with us, Sports Medicine Center, Akron Children's Hospital. Joe, I was talking to you about, I was going around the internet over the weekend, and I found some site that said prototype football helmets within the next decade, and they almost look like race car driver helmets, a little bit more formed and light it looked like, but it was complete enclosure of the face with the bar that came around front and then a visor. I don't know if that's someone in their basement just sketching something together, or what have you heard about and you and I have talked about helmet development, research, making a better football helmet.
No doubt,
anything
right?
More like that, maybe down the road?
We're counting on the engineers to help us here and come up with new devices and experimentation and research is super, super important. And the headgear is worth looking into quite a bit. Like I told you, the thing about in other sports, the thing in football is I wish there was a way to take away from using the helmet as a tool, as a weapon.
Right.
That's where we get into problems. And a lot of those sleeker, newer, lighter helmets actually feed into using it as a weapon even more. But I have seen those. And the look is meant to take away those rotational mechanism, those hit from the side. They do look, even the last generation looked a little bit more like a racing helmet, like you said. And the ones I see coming down the road are similar. The one that, if it could reduce the rotation of the head and reduce some of the snapping back of the head and the skull. But the biggest thing we also need to do, we got to try to get away from using the helmet as a weapon.
Yeah, that's the biggest thing. And I do say this, that in noticing and talking to a lot of coaches, I think they're doing a much better job of the proper technique teaching, sliding the head aside and stuff. But it's still the biggest factor. You know, when you watch these games on Saturday and Sundays, you're seeing those running backs lowering their head and trying to get that extra yard.
Right.
Now, defense, there's rules against them doing that. but still offensively, you're allowed to do it, and it's still a big factor.
That's still a deal that if they called it, it would be almost every other play in football, and we need to get a chance to get away from it. Yes, our hardworking coaches are teaching technique all summer long. We do good in Ohio with technique, but we need to do better.
All right, Joe, thanks for coming in.
Thanks, Ray.
There you go. Dr. Joe Congeni, Sports Medicine Center at Akron Children's Hospital, joining us in studio.